Chapter 17 in the Jarvis contains information about assessing male and female breast tissue and regional lymphatics. To get the most out of this chapter, make sure that you review the A and P, consider the developmental, cultural, and genetic differences, rehearse the subjective questionings out loud, practice the objective assessment on a willing simulated patient, review the documentation and case studies, and create flashcards, concept maps, create something to help retain the information. There is important teaching information in this chapter. We no longer teach self-breast examinations. It is no longer considered best practice. Instead, the recommendation is annual provider breast examination and screening, and then annual mammogram screening after the age of 40, unless they need it earlier for some reason. So your book covers breast surface anatomy, looking at the nipple, which is the center of the areola, which is the darkened area, some Montgomery glands, then kind of the underlying structures, the adipose tissue, the muscular structures, and the axillary tail of Spence. The internal anatomy includes the lactation system, so the lactiferous ducts and sinuses, and then the lobes and lobules. Also, it shows you ribs, adipose tissue, ligaments, and muscles that all kind of combine together to create the structures. The regional lymphatics in this area are incredibly significant. They're covered on page 387 in your textbook. If you are not familiar with these, I would go back and I would reread these pages just because this is the area where most likely you're going to find a lump is going to be an enlarged lymph node from collection of debris. So thinking about the way that the breast drains, it drains from the nipple areola up through any of the parasternal or the subscapular, or sorry, the central and pectoral chains. The subscapular chain is in the back, and so that's not usually one of the lymphatics that is involved with primary or initial breast cancer. So the lateral aspect of the lymph there actually drains from the arm. So if that gets inflamed, it's usually from something happening along the arm. But the subscapular, pectoral, and central axillary nodes all end up draining through the central axillary nodes to the subclavicular line and then back into the venous system. One of the things to think about is that anytime you're screening or assessing a developing child, so whether they're pre-adolescent, kind of that breast bud stage, or if they have mature breasts, they're going to have a lot of questions about how they compare to other people their age. Everyone obviously develops at a different rate and starting and stopping at different ages. So one of the most critical things is to show them like a sexual maturity chart and show them where they rate on that chart, and just tell them that they're normal. So their progress is normal, their development is normal. And that's true when you're doing like Tanner staging in men, or when you're doing breast exams in young women. Then you want to just let them know that everything is okay, even though if they don't look like everybody else. For pregnant women, there are some tissue changes in the breasts due to hormones. So you might see some enlargement, you might see some changes in color, the areolas darken, the breasts might feel more nodular, you might start to be able to get some colostrum or some discharge or drainage after the first trimester is over. And after menopause or after surgical menopause, so after a hysterectomy or even chemical menopause, so somebody who's taken Lupron to stop the secretion of estrogen and menstruation, the estrogen and progesterone levels are going to fall, and that causes atrophy of the glandular tissues of the breast. So the breast size starts to decrease, and you know that the breast tissue then starts to look kind of saggy. Breast lumps at this point may become more palpable because the subcutaneous tissue is less dense, and around the nipple, the actual lactiferous ducts are more palpable and feel firm and stringy because of all of the fibrous connective tissue and calcifications that were left over, especially if they had children and breastfed. And then there's a decrease in axillary hair, so decreased armpit hair with aging. Men have similar concerns. Men get breast cancer as well. So the male breast is much less developed as far as tissue goes, and obviously doesn't have like the lactation component, but it does have a rudimentary structure. And gynecomastia, which is male enlargement of the breast, is normal with hormonal changes and aging. So it's not uncommon, but it also could be due to things like decreased testosterone, cirrhosis of the liver, or other disease states. So you should always refer the man who has new onset gynecomastia for MD evaluation. It's also a side effect of some medications like higher dose risperidone and things like that. So let's talk about breast cancer for a moment, because one of the reasons, or probably the primary reason, that we screen breasts is to look for breast cancer, which is becoming more and more prevalent in the United States. You may have heard about the BRCA1 and BRCA2 genes, and your book does a nice job on page 389 kind of explaining what those are, but they're tumor suppressor genes, so they actually help prevent breast cancer. Women who inherit a mutation from one or both parents are at increased risk of developing breast and ovarian cancer because they don't have the tumor suppression ability for breast and ovarian cancer. Some people get genetic screening. Some people then preemptively do things like total hysterectomy, oophorectomy, bilateral radical mastectomies with reconstructive surgery. That is a personal choice. There, is an ethical debate, obviously, around that because some people don't believe that they should do that unless they actually have the cancer, and other people believe, it's free will and they should. Whether or not insurance companies pay for it is probably specific company to company. Table 17-2 on page 393 talks about breast cancer risk factors in women. And I just want to point out that the highest risk factors are women who are over the age of 65 or 65 and older, that have had biopsies, that have inherited those genes, that have a personal history or a parental history of breast cancer, or a sister has had breast cancer, and they have dense breasts on mammograms. So you should really be aware of those primary risk factors. Women who receive hormone replacement therapy have an increased risk because some cancers are sensitive to estrogen. So what do we recommend? We recommend annual screening mammograms starting at age 40. And we have a lot of health promotion programs in place to try to increase access to care. So in Vermont, we have programs in place for free mammograms and breast exams for women that do not have adequate health coverage. So when you're doing your subjective assessment, you want to ask all of these questions that are listed in the subjective part. Do you have pain, any lumps, any discharge, any rash, swelling, trauma? Do you have any history of breast disease? Have you had any surgery or radiation to your breasts? What medications do you take? Specifically, we're looking for things like, have you ever taken oral contraceptives or hormone replacement therapy? So again, we're looking for that estrogen, or the estrogen and progestin together. You can ask people if they do breast self-examinations. Again, it's not something that we're recommending or teaching anymore. It was triggering too many unnecessary mammograms, and women were receiving too much radiation for no reason because people were finding, hormonal fluctuation changes, and it was making them nervous, and then providers were feeling obligated to test them rather than using evidence-based practice. Examine the axilla, which are the armpits. This is called the tail of Spence. It's the area from kind of the side of the breast up into the armpit where that central lymph node system is located, and this is where the majority of breast cancers are actually located. So you want to know if there's any tenderness, lump, swelling, or rash in the central node area. Has the patient ever had a mammogram, and if so, when was the last one? And then you can ask any additional questions based on age and risk factor that you feel are relevant. So you're going to go and you're going to do a breast exam, and I realize that this is not something that you're going to do in acute care or in long-term care, but this might be something that you do in primary care, although typically this skill is reserved for NPs, PAs, MDs, DOs. So in your book, it outlines nicely how it happens. We're just going to run through it really quickly so you kind of understand the process. But this is not something that I expect that you would do in clinical, not even on maternity. I mean, you might do a superficial examination or a slight palpation of a breast to examine for like mastitis or a plugged duct or even like yeast in a cracked nipple, but I don't expect you to do breast exams in clinical. So the first thing that you're going to do is position the woman in the position of comfort, which may be sitting facing you, or it may be supine. You want to ensure privacy, comfort, and warmth so that the person doesn't feel too exposed or violated. Remember that they're probably feeling just as awkward as you the first couple of times that you do things. And this is true, like if the first time you put in a Foley, you feel really weird, and then after you've put in hundreds of Foleys, you're just kind of like, it doesn't even faze you anymore. That's the way you need to be about breasts and genitalia. Just when you look at it, it just needs to be very matter of fact, and it shouldn't even faze you anymore. Pillows are great, a little small pillow to help prop them up, keep them comfortable, and a ruler marked in centimeters in case you do find something is helpful as well. So you're going to look at the general appearance, and you're just looking at the symmetry of the breasts. You're making sure there aren't any lesions, and then you're just looking at the nipples to see whether or not there's any inversion, dimpling, or thickening of the skin. You're looking for any discoloration of the breasts or deviation of the nipples. Peau d'orange is the thickening of the skin and exaggerated hair follicles that is highly associated with breast cancer. You can kind of assess the female breast tissue and the male breast tissue during bed baths and ADLs, if applicable. So, if you feel like, you need to look at that area just to have a complete assessment, which does not hurt, you can tie it in with the other care to make the patient feel less awkward. So skin is normally smooth and even in color. There shouldn't be any redness, any bulging or dimpling. You might see veins underneath the skin, and then striae or stretch marks are normal as well, especially if the person had been pregnant or had gained and lost weight. You want to look at, first just observe the lymphatic system and the nipple. And again, they should be on the same plane and they should be kind of pointed in the same direction. You can sometimes have inversion of one or both nipples, which is fine, but usually they can be pulled out. But what you don't want to do is when you're staring at the breasts, they shouldn't look like they're cross-eyed or like a lazy eye. So both nipples should just in general be pointed in the same direction. So examine the armpits, the axilla while the woman is sitting, looking at the skin, looking for rashes, looking for any swelling. And then you want to reach your fingers high up into the axilla and move them firmly down in 4 directions. And your book gives a nice picture of this on 397. Move the woman's arm through a range of motion so that you can definitely feel in that entire area, keeping in mind that this is the part where you would most likely find a lump if one were present. Normal lymph nodes are not palpable, so you're going to hear that over and over again, but that's the truth. Normal lymph nodes are small and flat, and they're not palpable. So you might feel like small, soft, non-tender nodes in the central group, but you shouldn't feel any enlarged or tender lymph nodes in that area. You can also have the person check for fixation by having her put her hands on her hips, press her hands together in front of her, or lean forward or lift the arms overhead, and that just checks to make sure that the breast tissue is moving freely across the chest. So for the palpation part, you want to put the patient in a supine position. If you can put a small pad or pillow under the side that you're palpating and raise the arm overhead, it helps get the breast into the correct position. You want to use the pads of 3 fingers and just gently kind of press with kind of medium to deep palpation. You can go over light first, medium second, and then deep last to kind of feel for any superficial, moderate, or deep lymph nodes or lumps that might be present. You can do it either starting from the nipple and working out in a kind of circular motion, or you can do the vertical strip pattern, which is currently recommended. And that's the one that's shown in your book on 398. So women who have never been pregnant, the normal breast tissue feels firm, smooth, and elastic. After pregnancy, especially with lactation, the tissue feels softer and looser. When premenstrual engorgement, then there's tends to be firmer and more tender breast tissue, and sometimes women have to reschedule and come back because the breasts are difficult to examine in the premenstrual phase. It's normal along the bottom edge of the breast to feel like some ridge of tissue. And then after you've done your breast exam, you want to look at the nipples themselves. So you can see the picture in the book on 399, but you actually want to try to express milk or fluid from the nipple. If the patient does have a cancer in one of the ducts, you might get like a purulent discharge. So just look to see if you can express any breast milk during the exam or any other fluids. And if they mention that they have a lump or something has changed, make sure that you examine that carefully. If you are documenting a lump or a mass, you use the clock face, where like the head is 12 o'clock and the feet are 6 o'clock, and each breast then has a 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 going around it. And then you describe it in distance in centimeters from the nipple at the clock mark, and then judge the centimeters, judge it in centimeters, but in width, length, and thickness. So you're going to, again, just like we talked about in the skin assessment, pinch it up with your index finger and your thumb and try to kind of roll it around and see how big it is. Is it oval, round? Is it lobulated or indistinct? Helps kind of determine what the other underlying structure is. And is it soft, firm, or hard? And is it mobile, or does it feel like it's connected to something? And this is important because when they go for a mammogram and a follow-up ultrasound because they had an abnormal physical exam, it's helpful for the tech to know where it is that you palpated the mass. Is it solitary, or are there multiple? Is there any change in the nipple? Any redness, dimpling, or retraction of skin over the lump? Is it tender to palpation? And any other lymph nodes palpable in that region? So again, premenopausal women may have some swelling and pain that make it hard to detect lesions, and premenstrual women also may have some pain and swelling that make it difficult to detect lesions. So if you think that you might feel something, tell them to come back. The reason that they distinguish between premenopausal here on this slide is because premenopausal women are obviously older than premenstrual women, which increases their risk of breast cancer. For men, you want to examine the male, but just abbreviate it. So just inspect the chest wall, palpate the breast tissue, palpate the nipple area, and palpate the lymph nodes, and look for any of those skin changes, the dimpling, the nipple retraction, the fixation, the edema or peau d'orange with the thickening of skin and prominent follicles, and any deviation in nipple pointing, just as you would for the female.